just a second. Sorry. Yeah. So going forward, in the next few minutes, we are going to talk about how do we recognize clinical signs in a child who is closer to end of life. What are the benefits, burdens, and sometimes even ethical considerations that we have to think about? I know you you covered ethics last week, mainly around artificial nutrition, hydration, and also to think about blood transfusion, because that is one common scenario that oncologists and children with cancer diagnosis face. And also thinking about how do we think about life-limiting and life-sustaining treatments. So a common scenario that we all have seen, Ayan is diagnosed with high-risk ALL at age 5. He has received treatment, initial remission, then relapse, again underwent multiple chemotherapy regimens, bone marrow transplantation to 18 months later, he relapsed again with refractory disease. And oncology department has decided that further curative treatment isn't going to help this child. And the child is with increasing fatigue, appetite is reduced, has pain occasionally, is requiring frequent blood transfusions. And the parents are asking, if he stops eating, should we start tube feeding? Should we give him feed through the nose, or should we put a tube in the tummy? And what are some of the things, and I think this is where we can open for interaction. What are some of the things that you would do? If you're able to, please unmute yourself, but if you're not able to, chat is great too. What are some of the thoughts you have about this? If a parent asks you this question. Sorry, I'm trying to see if I can see you people. Anyone wants to speak? Parents are worried in the future the child might stop eating and they're asking you, oh, he's not eating well, should we put a tube? So some of the questions that I think we need to ask ourselves uh, is this part of the disease progression? What does the evidence say about tube feeding? Does it make the child better? What is the burden versus what is the benefit? And I think this is the language we use quite a bit, especially when it comes to deciding should we intervene, not intervene, is what is the risk, what is the burden, what versus what is the benefit for the child. And then also we have to remember that we are a culture where feeding is not just feeding, it's not just caloric intake, right? It's also about how we are showing love to the child. So even now, when we go to our parents' house, when we go to our relatives' house, what is the usual way they show us love? Oh, you have lost so much weight. Why don't you eat a little more? Take a little more. Let me serve you again, right? So in our culture, we have to remember that feeding is part of how they express love too, right? So when the child doesn't eat, parent is not just worried that my child is losing weight or he'll become weak. It's also that now they're helpless. They don't know how to show the love to their child. And we
Spandan,
will.
we just have an answer also from in the
Oh,
chat.
sorry.
Yeah.
Go ahead,
Dr.
Archana.
Hasina, she said, yes, very rightly, should not be forced. Parents must be counseled that his body requirements are decreasing and forceful feeding might increase suffering. Very true, thank you. And Dr. Muniba says, poor appetite may not be with disease progression. May or may not be with disease progression. Okay, yeah.
Yeah, thank you for that. And I do agree your point about may not be, because sometimes all the chemotherapy, all the treatments that the child is receiving, it in itself can decrease the appetite, right? But also, especially when a disease is considered refractory and when it is an oncology diagnosis, it's mostly a part of disease progression, is what I would jump to a conclusion of. And we will talk a little more about this, but then 5 weeks later, Ayan now is sleeping most of the day, has stopped going to school, and eats very small amounts of food. And he's requiring weekly blood transfusions for symptomatic anemia. And this is again something we see again and again in oncology centers. So parents are asking you, he feels better after transfusions. Can we keep doing them? What is your answer for that? I'll wait a bit longer now because I think answers are coming. But if you're able to unmute yourself and speak, happy to listen to that too. Yeah, you're right, Muniba. It could be disease, it could be drug too. Any other thoughts? Like, especially, it's refractory. They're coming back again and again to your hospital to take blood transfusions because of the child's anemia. And he's feeling better after transfusion because, yeah, he has. I think Kumar
We have
has
a
said,
chat. Yes.
yeah,
Deferred transfusion has no net benefit, Dr. Kumar says.
yeah. Any problems you foresee with that decision? If you as oncologist are telling that let us defer this because there is no benefit, like what do you foresee the problems? The child will become symptomatic after a week, right? Because his cycle right now is weekly in requirement of transfusion. And when someone becomes symptomatic, what happens, especially anemia, gets breathless or he gets palpitations. Yes, anemia, respiratory distress. And then the family keeps saying, oh no, but he's breathless. So you need to transfuse, doctor. Why are you stopping? Right? We will pay for it. So what next? Any thoughts? I totally agree with you, Dr. Kumar. Like, I'm not saying you're wrong. I'm just asking you what next. Yeah, blood transfusion may improve quality of life. I agree with you. We will talk a little more about this. The reason why I'm bringing all these scenarios are these are very common and we face them in our day to day in our practice. And I want us to think about it as we go through the slides. Scenario three, same Ayan, 3 weeks later, he deteriorates further, mostly bedbound, doesn't take anything through the mouth, increased sleeping, is not breathing well, his urine output is very less, he has cold peripheries and peripheral mottling. And parents ask us, he isn't eating anymore or drinking anymore. Won't he starve? Shouldn't we force feed him something? Because he will die if he doesn't eat, right? Uh, Again, I've seen this happen many times in my practice, and I'm sure uh, you have faced it too. So, what would you say? Parents are asking you, my child doesn't have energy. He's dying because he's not eating. Please feed him something and he will be a little better. What is that answer? Yeah, cachexia, Muniba, you're right. But my question is again, like for cachexia, when parents ask, please feed, my child is dying because he's not eating. Hasina, thank you. The child is nearing end of life. So what would you say to the parent? How would
Dr.
you as a
Shruti has
doctor?
raised her hand. Yeah, please unmute Dr. Shruti.
Oh, oh,
Thank you,
please.
Dr. Rachna and Spandana. I'm sorry, but sometimes I feel there is no right or wrong answer for this. It's all about sitting together with the family and discussing, what is worrying them the most and, talk about that, what is causing the disease progression, what is causing weight loss and loss of appetite. And at times there is this dilemma of, you know, uh, fulfilling the parents' wish versus fulfilling the child's wish, because parents are going to live with that trauma throughout their life. So, saying no, sometimes it's very painful. I'm just expressing it because it's something that I kind of felt at times. If I'm saying no and the parents desperately want it, and anyways, the child is already not so good. So, should we kind of look at child's wish or look at parents' wish, because they are also the ones who are suffering in the entire process. So it's all about sitting down, discussing, and coming to uh, common ground and doing what is best at that point of time for the entire family.
Yeah, you're exactly right, Shruti. And also what Kumar has put in the chat about cannulation is unnecessary, blood-borne infection, no long-term benefit. All of you are right. And as you said, there is no right or wrong answer, right? We are trying to do the best for the child. The only question is, how do we navigate that? And I think that's what I'm hoping to make us think about. Instead of us saying we have to actively listen and communicate well with the parents, what would be one sentence that we would use probably to explore more? What are some of the things we can think? Yeah, I see Anjana saying we should explain that he's dying and that's why he's not eating, not that he's not eating and he's dying because of it. That's exactly true, right? Like the child is dying and that's why his body doesn't want food. It's not that he's not taking food and he's dying. But again, Anjana, how would you say that in words to this family? Do you want to try it? If I was the mother and I'm asking you, please feed my child, how would you say that?
Uh, that his body is not is shutting down slowly and is not ready to accept any food as of now, and we're not going to help him by giving him any more food, and instead we might harm him and cause more discomfort. So we'd rather wait and watch. That's
Fantastic. I think that's a very gentle way of sharing news, right? Thank you for that. And I'm just thinking there are a few other things probably we can definitely say as an extension to that, but that's a very good starting point. Uh, Making parents see what we are seeing as healthcare professional is our job too. And scenario 4 is Ayan's hemoglobin drops again. He's, as you know, very, very lethargic, is in the bed. And the oncology team is asked, we are asking ourselves now, should we give another transfusion? And the family is now worried that if you give another transfusion, it will begin the cycle of, again, maybe he will feel better and then he will feel worse, which is again true. So going back to the presentation, and while we go through this presentation, please, if you have any questions, please put them on the chat, or after the presentation, we can discuss a little more about it. Just thinking about when there is no realistic hope for a cure, especially in terms of oncology and cancer, we think the child is closer to end of life. And it might be very, very different for different children. And that is why we never say that this is the time that the child will die. Usually, when parents say, how much more time we have for the child, we always give a range instead of a certain time period. And then we are looking for functional changes in the child, especially Ayan. We saw that from the beginning, he went to school, then he stopped going to school, then he started sleeping more, then he stopped eating much, and then his breathing became different. So his functional changes were a guide for us to say that he was close to end of life. And then remember, a lot of the times predicting end of life, especially in children, it's very difficult because they tend to hold on quite longer in our practice. So we can only say it is end of life mostly in a retrospective view after everything happens, and then we connect everything, right? And when we think about how do we plan for end of life, always think what is the natural history of the disease. Sometimes I feel cancer is a little more straightforward. When no more treatment, you know the child is dying. Whereas non-cancer is more challenging sometimes in terms of predicting what would happen. And then thinking about child's fragility. Are you expecting a sudden deterioration, or do you think this child will slowly deteriorate? And then how much are these parents in need of information and guidance? I think we have to ask ourselves these questions every time before we start into go ahead with the conversation. And when we think about end of life, location is always a big thing, especially in countries like India, where financial limitations also play into the whole care of the child. And they went and looked at some evidence, and they have done a survey with children, and they have 75% of them want to discuss end of life before much early in their disease trajectory. Only 12% of them said they don't want to discuss it. And most of these adolescents, they have said they prefer to die at home. But then again, how important it is to know whether it is a natural death or dying at home and wanting to know if I was dying, that was little vague. So, but the takeaway is, especially adolescents, they want to know, they want to be involved in their death decisions. And if there is an option, sometimes they prefer home more than a hospital. And then when we talk to families, and if you are talking to children, we need to listen a lot more and we need to understand what are they seeing, what is their experience with dying. So if this family has never seen death as such, so it would be much more confusing for them, right? But if they have had few deaths in the family recently or with cancer, their understanding of what end of life is might be very, very different. What are their worries? What are their hopes? And these hopes can be location, who will be there with the child, and also how comfortable the child should be. He shouldn't feel anything. Recently, I had an end of life child, and the father kept saying, I don't want her to be awake because when she's awake, she's uncomfortable. I want her sleeping. And that is something Dr. Archana would talk about a little more. He refused to keep his child awake because of the amount of discomfort the child was in when she was awake. And then thinking about family meetings, especially around end of life, even before you call family meetings and not just calling the parents, I would think who else needs to know this information and how much information do they need? Who are the decision makers? Because caregivers and decision makers in our context in India are very different. You might see by the bedside grandmother and the mother, and probably the maternal grandfather is the decision maker because he's paying for everything this child is receiving treatment for. So we have to think about who are the decision makers. Early discussion, sometimes using hypothetical circumstances. So when I go into this meeting with Ayan's parents, I might not always use the language. Well, about Ayan, I might say some children that I take care of decide, some families that I care for decide for more transfusion. Some families realize that these transfusions can be more painful and ask for no transfusion. What would be your choice? So sometimes removing them from the situation makes a difference for them. What is the family's understanding as you discuss prognosis is a very important one. Eliciting goals of care in light of understanding of prognosis. So I think this is one of the biggest job when you are applying palliative care principles in oncology is understanding what does this family value the most. Do they want comfort? Do they want to feel that? Because as Shruti has pointed out, some families want to do everything possible, right? And I now practice in a high income setting. And here, what I have seen is I worked in a low income setting. I came to a high income setting. And then I've realized I came with this idea that don't push the family, don't give more treatment to the child, you're hurting the child. But in a high income setting, they want ventilator, they want TPN, total parenteral nutrition, they want all these things. And then I have realized this child is going to pass away irrespective, right? But the family has to live with that grief, and they are the ones who are bereaved. And sometimes doing everything, including ventilation, uh, might be important for the family. As much as it is not good for the child, it is probably what is that family wants in the moment. And we as healthcare professionals should communicate gently, should make them see what the point is. And even after we express our opinions, if the family takes the route of aggressive treatments, I think that's where my focus would be solely on the comfort of the child when he's still getting aggressive treatments so that he doesn't feel pain for them. And then thinking about, I don't know if you were already introduced to the PEST model, which is physical, emotional, social, spiritual, and thinking about trajectory. And this helps us assess the situation of the child to make a better care plan. And then when we are talking to the parents, especially what one of you has mentioned about family meeting, I think we have to remember we are trained to see how death looks like. and the family is not looking at it at the same way. So we are saying things like, this is what I see is happening, right? And I see the child is not taking anything. The breathing, as you can see, has changed. Your child is not passing as much urine. You can touch the hands and the feet. They're cold. And all these are the body shutting down, right? And this will help them not feel much of the things. So, for example, there are a few things, especially when a child is dehydrated, the secretions are much less. And when carbon dioxide increases because of the breathing changes, they become more unconscious, right? So these are the things the body is naturally doing to keep the child comfortable. And as long as what we see, the child is comfortable, the child is not moaning, the face is relaxed, we are going to keep the child this. But if the child is uncomfortable, if he starts making any sound, if you think he is in pain, we will change the medication, we will increase the medication. Does it sound okay to you? So this is something I see that every time I have to go through with the families to reassure them that the child is comfortable. And some of them want monitoring, want to see heart rate, want to see saturation. And that's when I say, I'm not going to treat the numbers anymore. I'm going to look at Ayan. I'm going to look at his face. I'm going to look at his body. As long as he's comfortable to my eyes, I'm going to keep him in the same way. Is that okay with you? Is it okay if I remove the monitor? There are some families who insist that the monitor be attached. We leave it that way. But there are some families after a point, let us remove it. And some of them ask every shift, can you just check it once and we do that? So continuous monitoring is not something we do. And then thinking about when you bring all these things into these conversations, we need to be prepared for emotions. There might be guilt, there might be hope. And then people are thinking about quantity versus quality of life. And I think every time all these things come up, we have to bring them back to what is our goal of care with Ayan? How do we want to take care of them? What is the most important thing for Ayan right now? That he is comfortable. And that's what we are going to do. Again, thinking about sometimes even when parents especially ask you questions like, should we give feeding, tube feeding? Should we give more transfusions? So it is always good to ask them, can you tell me what you understand by tube feeding? What do you understand by, what do you think the transfusions are doing for him? It's very important to understand that because we imagine parents know everything about blood transfusions, everything about tube feeding because they're asking that option or because they have stayed in hospital for months together. But I think we always need to ask, tell me what you're seeing and can you tell me what this intervention is doing for your child? And also using sentences like, I see that she's not eating since many days and her body is weak. What do you see? Are you seeing the same thing? Do you see her breathing has changed? Do you see the same thing? So just making sure you and the parents and the family who are by the bedside are seeing the same thing. And also this is something we spoke during communication is wish, worry, wonder approach, using sentences like, I wish I had better news. I wish things were different. And I worry the time is very less. I wonder if there is anything else we can do to make you feel that we can do more for the child. So just remembering the earlier communication discussions to be used here. And also thinking about few sentences. Again, this is why I said, do you have any sentences that you have in your tool book to use? As difficult as this is to say, in light of my understanding of your child's condition, if the child's heart should stop, I believe that means that he has reached the natural end of his life. As such, I would recommend that the child receive comfort measures and not active resuscitation. Does this make sense? And I've tried using this with one mother, and she did not understand what resuscitation meant. And so I said, You were in hospital with your child for a long time. Have you ever seen anyone try to restart the heart? And then she said, yes, in the same ward, this happened for a different child. And I said, okay, do you know why they did that? And she said, yeah, the heart stopped. So they tried to restart the heart of the child. But do you see why it won't be helpful for Ayan? Because heart stopping, someone is walking in the mall, someone is in a road traffic accident. It was unexpected. So that is why we try to revive them. But for Ryan, the natural course is that his heart would stop. So trying to restart the heart would only prolong his, I would say, problem, suffering, might prolong his suffering. So would you still want it, or do you agree with me that we shouldn't be doing that? So again, just thinking about this is something we have already said, thinking about hypothetical situation, and also thinking about what is good care, what is not good care, and what is a parent's perspective of what is good care and what is not good care. And I'll tell you a few other things that, because one of you has very nicely mentioned that I will tell all this to the parents and say, let's wait and watch. But again, thinking about parents, it's one of the most difficult things for them to wait and watch. And I remember once a father was telling me that it is like I'm waiting for my child to die. It's like I'm hoping for my child to die. And I know he's dying, and I'm just sitting there doing nothing so that once all this is done, I can get on with my life. So they carry a lot of guilt, even with wait and watch policies, right? And also to think about the language not to use. And this is something we do again and again. What would you like us to do? Remember, we are not a restaurant. We are not carrying a menu. So what do you want, sir? That's not what we are trying to do. We are trying to do the best for the child. So asking a parent, what is it you want us to do, is not a good question. Would you like us to do everything or do nothing? And this is something I still hear to this date in hospitals, is that do everything. So if I were the parent and I did not have medical background, and if someone asks me, why imagine healthcare? Imagine like if I've paid for a special experience for my child, and they say, do you want your child to get everything or nothing? Of course, I want everything for my child if it's a simple experience, right? Imagine in healthcare, do you think they will ever say, don't do everything for my child? They will always say, do everything for my child. But it is our job to define what that means. So this sentence is a big no, don't use it in the future. And also questions like, do you want your child to be intubated? Do you want us to do compressions? Do you want defibrillation? These are not good questions to ask. And also constantly telling parents sign DNR, or I've seen this happen in some hospitals, especially when families agree not to do much. And the child is in a PICU setting, and they have said, okay, if the heart stops naturally, don't do resuscitation. We make them sign every shift. And parents have said that they feel they're signing death warrant for their child. Like, oh, it's okay for my child to be dead. So again, remembering that the parent signing is not going to protect us legally. And like, what is the point of making them sign if it's only going to cause more distress and break the trust between the healthcare professional and the parent, is something we all have to rethink. And then this is the thing I wanted to tell you. When you tell parents, wait and watch, it's very difficult to them. And sometimes when their child is not like their child anymore, because the child is sick, not talking, sleeping more, they don't know what to do themselves. It's sometimes it's not very intuitive, right? Like usually parents know how to take care of their children, but a dying child, they might not. So this is when I think we as healthcare professionals should encourage things. There are some of the things that you can do. Hold her, you can clean her mouth, you can wipe it every 1 hour, you can sing a song, tell stories. And this is something we tell everyone, that hearing is the last sense to go. So even if the child is not opening the eyes, even if the child is not hugging back, right? Hearing is something that we think they do till the last. So telling them they can hear you, please talk to them, please tell them stories, right? And also asking, who are the extended family you want to be involved? Have they said their goodbye? Do they want to come see the child? And this is something I've done even in very close to end of life situations where I would say, do you want to hold the baby and take a picture of with the baby? I had a newborn with a huge omphalocele and some syndrome, and the mother never held the baby. The baby passed away. And I asked the parents, some families like to hug the child and take pictures, and some families don't prefer. I don't know what you would like, but I just wanted you to know if this is of interest to you, I can take some pictures for you in your mobile phone. And the father was horrified with the idea. He said, no, no, I don't want pictures. Like, no, I don't want to touch. And but the mother was like, yes, can I hold the baby? Can I take some pictures? And we took pictures. So again, same family, wife and husband, very loving wife and husband, but they wanted different ways of dealing with that grief. So trying to offer this, I think, is important. Just looking at the time. And then saying things, sometimes telling, you need to tell, I love you. There are some children who are very, very attached to their parents in terms of they don't let their parents even go to the toilet, right? They're like, be here, be here. So telling the parents to tell them, you will always be with me. You will be okay. I love you. I'm proud of you. So helping parents use language to show the love, I think it's a great way to think about. And also thinking about uh, bathing the baby, changing position, changing clothes, putting on fresh clothes every day, and telling them, when you watch anything, like if the child is moaning or anything, can you tell the nurse? The family feels they're doing something for the child. So that is one more thing. And reading books, listening to music, some good smells, holy books. I have had families who insisted they give bath to child morning and evening so that they're very clean and they're not unclean when the death happens, and thinking about other complementary therapies to keep the child comfortable. So just thinking about the big picture, especially when anticipating death, is assessment, the big picture stuff, communication, developing a plan, and educating. I'll not spend a lot of time on this because Vinila will share the slides with you and you can look at it and you know most of what comes in it. Just thinking about systems and how different systems change during end of life is one thing I just wanted to highlight. And then thinking about days to weeks before, there is weight loss, respiratory changes, sleeping, and less activity. And few hours before, it's mostly that gurgling sound that comes from throat. I don't know if you have heard it. Again, the last child I have cared for had a lot of gurgling sound, and it is very, very distressful for the family. And we had to keep reminding them that this gurgling sound is because there are secretions pooling, but also the tone of the muscles goes down and they're not uncomfortable with it, but we are uncomfortable because of the sound. And thinking about, is it possible to involve spiritual counselors or any psychological, psychosocial workers? Thinking about cultural aspects of care, again, thinking about when the death happens, how do we take care of the body? And even before death, what are the things that we need to do? And physical symptoms. No amount of nice things we do, nice things we say will work, sorry, will work if we are not managing the physical symptoms. So if the child is uncomfortable physically, no matter what we do isn't going to help. Sorry, one second. Yeah. And then thinking about end of life logistics, when the death happens, one second. Oh my God. Someone from family is calling, sorry. Yeah, end of life logistics, thinking about preferred location of death. who is present, memory making, what to be done, funeral planning. These are very important. And I think all the more important in India, where people travel hundreds of kilometers to take treatment. And when death happens, suddenly the transportation goes up by 3 to 4 times. So earlier, if they have to go home in an ambulance with a live child, it would cost 8,000, 10,000. But to take a dead body, it would take 40,000, right? Like, so that is the reality in India. And then thinking about what are our own staff concerns or distress. And this happens again and again. We think it's part of our job, but it's very distressing, especially if with all the empathy we practice, it becomes difficult. At end of life, I think we all have to review the medication again, like especially thinking about what is this medicine doing for the child? Does this child's physiology have something changed that will alter the effect? For example, renal liver failure. For example, if a child is in renal failure, probably I would convert morphine to fentanyl, or I will decrease the frequency of morphine if I don't have access to fentanyl, because we know morphine gets excreted through the renal system. And then thinking about, should I add any new medications, especially like supplements, vitamin D, corticosteroids, all of these, especially at end of life, are not super helpful. So I would just remove those things. I would keep medications on the prescription, which are helpful for the child. And thinking about nutrition and hydration, children who can communicate the needs, especially if they're still verbal, uh, to remember that to give them based on their desire, right? Like, I want this, you give it to them. And one of you has rightly said, these children are not dying because they're not eating. They're not eating because they're dying. And then these are the reasons why the hunger goes down. What you have said, cachexia, but anorexia, thinking about the gut motility goes down, hunger cues go down, there is reflux, there is nausea, vomiting, there is cramping, sometimes bowel perforation might be there. And these are some of the important things to consider. Again, anything I give at this time is for the pleasure of the child. This is not that the child has to grow or develop well. So yeah, at Hyderabad Hospice, there were times when the child would wake up in the morning and would say, I want ice cream. And we allowed the child to have ice cream, right, for breakfast. And they would say, I want thumbs up, I want Coca-Cola. And we would allow them to have anything. Parents are usually like, no, no, don't eat. Because usually in cancer, we tell them during treatments, don't give junk food. So parents are so scared to give it. And I think this is the time we need to give that permission to the parents that, no, let the child eat for pleasure. And one other thing, which I think is very, very important, if they cannot swallow, if they cannot chew, sometimes just letting them hold the food in the mouth and spitting it out might be done too. And this is something few of the children do time to time. And then there is something called, again, I came across this word term. We have done it before, but I didn't know there was an official term for it before. It's called permissive undernutrition. You're not malnourishing the child, but you let them not grow in weight, or you don't overfeed them, or you don't meet the caloric requirements the body needs, knowing that if you try to meet the caloric requirements, the child will have side effects because of this. So this could be intolerance, vomitings, and things like that. So especially this one. And if you expect the death in days to weeks, remember to decrease the IV fluids or feeding that you're giving, because the more fluids you give, the more it settles as edema in the body. So there is swelling in the body, but also it goes to the lungs, but all upper respiratory tract, and creates a lot of sound and distress for the child. And then thinking about feeding intolerance, to recognize it, anticipatory guidance, and negotiating with family. And as I told you, in our culture, it might be unacceptable for families to see their children are not getting something. So they might argue with you, please keep giving fluids. And that's when I tell them, so what I will do is I will start fluids. We will see if there are any side effects. If there are side effects, you will let me know and we will decrease the food. And sometimes I've started it, and the child would have a lot of secretions, and the family would request to decrease and stop the feeds themselves. So again, as you have said, there is no right answer sometimes, and we cannot take away anything forcefully from the family because the guilt would be something they would carry for a long time. And then when we are not feeding the child, when we are not giving oral feeds, thinking about how to take care of the mouth, use of ice chips, freezies. So I don't know if you know, sometimes what we do is the ice cube tray that we get, we fill it 1/4 with mango juice, appy, or some kind of liquid fruit juice. And once it's frozen, we remove it and put it in the mouth of the child so they have some flavor in their mouth. And it's not a high quantity, right? Like 5 ml, 10 ml, and that makes a difference. So it's like tasters, freezies are something that you can try with these children. And the family feels good because now the child is getting something. It could be chocolate milk that is frozen, and this is something that they find helpful. I will not go through everything, but all I want to say about blood transfusion is think about what are the benefits versus what are the risks. And the way I talk to families about benefit versus risk is thinking about, can they afford it? Can they travel that often? And how long the child's transfusions last him. So some families keep taking transfusions. Initially, it is monthly ones. Then you can see the time has come down to 2 weeks. And sometimes after a point, especially when platelets are involved, it's almost every day they have to come for transfusion. And sometimes I use that to explain to them, do you remember your child needed transfusions earlier, monthly ones, but now it has come down to every day? Do you understand why? And that gives us that opening to talk about it. And also remember, as oncologists, as people who work in cancer departments, we are the ones who push these families to make sure you test the blood, make sure you take blood transfusion. If there is a fever, you need to take antibiotic within 24 hours. Remember, we trained them all this because we were hoping for a cure. Now that the cure has shifted to comfort, the parents cannot just start seeing that like us. So we have to help them see that. And again, thinking about when death approaches, again, there might be vision-like experiences. The child might start seeing something, the eyes might look different, temperature might be different, circulatory and respiratory changes might be different. And thinking about our own things, right? Like I have staff sometimes who get more anxious than the family, and I know they need extra support. So making sure they get that support. And sometimes even we as doctors don't want to go into certain rooms because it's very difficult for us to see the child not doing well, family doing that. So to remember that I'm trying to avoid this room because it's uncomfortable for me, but me being there is going to help the family. So we are not doing just something, but we are just being there with the family. And sometimes there are questions like, should staff attend funerals, remembrance days? I think yes, if the family wants you to, I think we can attend funerals and wakes if it's possible for you, if your schedule allows. But also thinking about writing a condolence letter. And when we write the letter, what are some of the things that we think about is writing a personal memory, acknowledgement of the child that you did everything possible for your child. I think that's very important for families to hear from us who have seen them through all the trajectory. And also, we can include a statement that says it's a privilege to be part of your child's care, right? So, to remember all these things. To sum it all up, when it comes to communication, always start with understanding what changes have you noticed, what are your biggest worries, share your clinical assessment, tell them what you see from your end, explain benefits versus the risk, especially artificial feeding, how, as you have said, Cannulation can be a problem, NG tube can be a problem, overload can be a problem. Transfusions, it gives temporary effect versus coming all the way to the hospital. And like, what is more important for you, Rasna? What would you like for your child? And then both of us agreeing for the plan. And then thinking about how to take care of the child, especially the clinical assessment pathway. Uh, Again, you have seen that the child is close to end of life. You have checked functional intake, physiological, neurological conditions. Uh, Again, multiple indicators present, maybe last few days. Then think about what are the clinical actions. Again, clarifying goals of care, anticipating symptoms, reviewing interventions, such as what are we going to do for this child, and then focusing on just the comfort care and avoiding any aggressive interventions. And the key takeaways is always prepare the family, reduced eating and drinking are natural in the dying process. Artificial nutrition and hydration, especially in oncology end of life, doesn't improve, and even in non-oncology end of life, doesn't improve comfort. Transfusions should be symptom guided and regularly assessed, but also in agreement with the family. And for a better end of life care, I think shared decision making is very, very important. I'll hand it over to Archana.
Thank you, Spandana. It's always so nice to listen to you. And it's also difficult for me to speak after you speak, so I'll just start. Uh, Yeah, so in continuation with what Dr. Spandana was mentioning, when children go into end of life, she's very well summarized and explained how best we can manage their symptoms. But there are many scenarios where we come across that we may not be able to manage the child in terms of comfort with the regular medications and regular care plan. So in such situations, we need to go a little bit more with expertise. And the topic for today would be palliative sedation or deep continuous sedation or therapeutic sedation. So any of the terms mean the same. So again, coming to an example.
Can you make full screen now?
Oh, sorry. Yes. So coming to an example again, most of you would come across such scenarios. We have a 2-year-old child with metastatic neuroblastoma who's having episodes of screaming and restlessness, who's not been sleeping for days. And because the child is not sleeping, the family is also not sleeping. They're very anxious and exhausted. The child already has been on multiple medications to control pain, including opioids, that is methadone, and also gabapentin, dexamethasone, etc. So now the child is developing neuroirritable symptoms, and you had a class, I think, on assessment of distress or pain in a sick child. So as per that, the placard, what we use for sick children who do not communicate is 6, which is significant. Anything more than 3 is significant. So how do we manage this child? We have given her a lot of medications. We have given her the medications of choice for the control of pain, but the child is still restless and in pain, and we just cannot leave the child like this to suffer. So coming to refractory symptoms, we have another term which all of us are aware, which are called difficult symptoms. So these symptoms are the symptoms which respond within a tolerable time frame to different aggressive interventions which yield adequate relief and preserve consciousness without excessive adverse results. So here the key words are that there is adequate relief in a tolerable time, and the consciousness is preserved, and there are no excessive adverse results. We need to remember this because when we come to refractory symptoms, symptoms for which all possible treatments have failed. So we saw in the previous case, even opioids were given, steroids were given, adjuvants were given, or no methods are available for palliation. Sorry. Oh. Vinila, how do I close this? This bar, 1 minute.
Which bar, ma'am? Sorry.
This bar is coming in. Yeah. Okay. I'll push it up. Yeah.
You can
Sorry.
just drag it and
Yes, yes.
put it
So
down.
yes. Sorry, yeah. So and no methods are available for palliation in this time frame. As I said, there you have a specific time frame that you expect there is a relief. Here you don't have that time frame which is there, and also the risk benefit ratio that the patient can tolerate is not as expected when you have difficult symptoms to treat. So you have difficult symptoms and you have refractory symptoms. For difficult symptoms, we always have a ladder like a WHO pain ladder or a neuropathic pain ladder or a delirium pain ladder, where which we go one by one and treat with different medications. In refractory symptoms, all the medications have been tried, and within the expected time, there is no adequate relief. And also, we know that the risk benefit ratio that the patient can tolerate is not acceptable. So coming to different kinds of sedation that we usually use in palliative care is transient sedation, which all of you know for noxious procedures. It might be for any intrathecal procedure or a little bigger procedure where we need the child to be sedated for a longer time. It also can be for sedation used in end of life, weaning from ventilator support. This is usually done in compassionate extubations, where this also we use a lot in non-cancer palliative care, wherein the child is immediately ventilated because withholding ventilation is normally preferred, but usually the child goes on ventilator and then it is withdrawn. So in that case, we use sedation. And also in cancer, usually sedation for refractory symptoms at the end of life. So therapeutic or palliative sedation, what we call, it is the monitored use of medications, which results in inducing a state of decreased or absent awareness. And our intent here is to relieve the burden, which was not initially controlled with a lot of medications. And it should be also ethically acceptable to the patient, family, and also to the healthcare providers. Here, healthcare providers are again the primary team and the pediatric palliative care team. So few keywords which are very important is it's a monitored use of medications to relieve the suffering after trying a lot of medications. It should be the symptoms should be refractory, and it also should be ethically acceptable. So now the question comes, is it euthanasia? So I would like kindly request Vinila to put a poll and just to see what everybody thinks of this. Is it a palliative sedation? Is it euthanasia? Do you think it's euthanasia? Please put a poll just to know what we all think. Very good. Okay, fine. It was instant. Thank you, Vinila. Yes, as you all know, it's not euthanasia because the very intent in euthanasia is different, and it's very different in palliative sedation. So here the intent is to kill and there is no monitoring. Of course, the medication can be prescribed. There are different types of euthanasia. We won't go into detail. It can be by the patient himself, or it can be by an assisted person. So just to make a point that, because many a times when we talk about this, then we get questions from the families that is it euthanasia? So many a times, because they think palliative care is again end of life care only, and then it is something around euthanasia. So we need to be very clear. And also, one is intent is not to kill, and second, it is a monitored sedation. So more about it. Before we go into that, we also know that the data, whatever is there, shows that neither the administration of palliative sedation nor the degree of sedation hastens death in otherwise terminally ill patients. So this is very, very important. Unless we know this, only then we can encourage and plan for a palliative sedation. Otherwise, there'll always be a point of guilt or apprehension on the part of health workers. So it's an extraordinary intervention requiring expertise in clinical care, a very good communication, which is already emphasized by Spandana, the common shared decision, and also interdisciplinary team process, which is very important. So it's always a decision between the primary team and the pediatric palliative care team. So we are seeing refractory symptoms. So what are the refractory symptoms? It is found that the maximum symptom at end of life, which is refractory, is restlessness or terminal agitation. Then comes breathlessness, and then pain. Usually we see in end of life, somehow the pain is not as much in before part trajectory of the illness. and then followed by nausea and vomiting. But I remember children being given palliative sedation for almost all these symptoms. And yesterday itself, we had a child for whom we started palliative sedation in the hospice, a child with fibromyomyxoma with in end of life. For breathlessness, we had to start, but we have also started children who had severe nausea and vomiting, unable to eat, and restlessness, and also pain. There was a child who was very delirious, and again, it was refractories for whom we had to start palliative sedation. So there should be for whom shall we start palliative sedation? So we need to have the specific indication. It should be a presence of a terminal illness. The symptoms should be refractory. And by that time, you have tried all modes of managing the symptoms well. It can be oral, it can be subcutaneous, it can be patch, it can be IV, it can be infusions. You should have a do not resuscitate order already planned, and it should be explicit wish by the patient or the proxy with an informed consent. And here again, the intent is to decrease the suffering. Palliative sedation means not just sedating the patient. Every time we communicate, it is something what we are doing to decrease the suffering and keep the child comfortable. And again, everybody in the team should agree that we have done our best till then to keep the child comfortable, and now we need to start palliative sedation. There should not be any difference of opinion within the team. So the child must be evaluated by a clinician with sufficient experience and expertise in palliative care. Simultaneously, multidisciplinary evaluation is very important. Again, the present history, the present investigation, the relevant physical findings, the spiritual evaluation, and also psychosocial and other emotional issues what the child and family had gone through. So when we start palliative sedation, the level of sedation we aim at is the lowest necessary to provide adequate relief of suffering. So we will see that the child has the maximum comfort in terms of his suffering or symptoms with minimum sedation. So the level of sedation should be always directly proportional to the symptom relief. So many a times when we start the child on palliative sedation, maybe even the parents tell us that let the child, we know that the child might not have the consciousness like before, but for few hours when we start the sedation, then the child will be very comfortable, and then they say that he should not be so unconscious that he won't recognize in case any of his family members come. So we see to a level that he will meet them in case any visit is planned by the family, but yet he'll be comfortable. In that way, slowly the medications are titrated and then increased or decreased. So when the parents see that the child was very comfortable for 6 hours, again when the medication is titrated on the lower side, then again they feel that till now the child was comfortable, so why don't we continue the same medication for another 6 hours. That's how slowly, initially we never plan for 24 hours palliative sedation. It's usually started in the night so that the child sleeps well, because the child will have a better quality of life in the morning. But when the parents know that the child is very comfortable on this, then they request for a better and longer comfort through palliative sedation. The drugs what we usually use are a group of benzodiazepines, neuroleptics, propofol and dexmedetomidine, and ketamine. One important thing what we need to remember is that opioids alone should not be used for palliative sedation, because they do not provide adequate sedation. So usually it is always a combination of morphine, midazolam and haloperidol. It all depends on what symptom we are focusing on. So if it's breathlessness, the main symptom, then maybe we'll be adding midazolam, and then since we all know that opioid also has a role in treating breathlessness in end of life, then maybe a little bit of morphine. But because we are giving a lot of morphine infusion, then we know that it can be a risk for inducing delirium. So then we also add a dose of haloperidol. But otherwise, we can go with any of these drugs. And it is usually what that hospital or hospice, they have their own policy for palliative sedation. So when we start palliative sedation, we should again have our goal of care. So once we put the child on sedation, we have to monitor the vitals. It may not be as regular how it is done in the ICU, but at least as Pandana said, it should be done every shift. We need to see the urine output and symptom assessment. The very fact we have started this palliative sedation is for the symptom management. So we need to see how much the child is benefited by what we started. So this also has to be done, and we have different scales for pain, for respiratory distress, for delirium, for irritability. So we have different scales. If the child is having in non-cancer, we have a lot of children who have severe spasticity or dystonia. So even in terms of those things, we can scale and score and then see if our sedation is working to help the child. Again, we need to see how much aware the child is and how much sedated the child is. In all this, we should never ever forget to keep the child comfortable in terms of the bed hygiene, the clothing, as she said, the diaper, and see that the child, just because the child is on palliative sedation, we should not forget that the dignity has to be provided. And now this is, you can see it online. It's called the RAS score, wherein our focus will be to keep the child in between 0 and -2 in terms of the sedation. So it's not that you just start something and then slowly the child might sleep and then will not wake up at once. It's not like that. It is a very monitored process, and our goal will be to keep RAS of 0 to -2. But maybe at one point of time, even at -2, the child may not be very comfortable, then you have to increase. But initially, we need to titrate and see. So once when we start them on palliative sedation, again, as I said, daily or hourly review should be there. And the general comfort measures, again, about hair, about skin, moisturizing the skin, position of the child, all this needs to be taken care of. And every time, initially, definitely all this is started after multiple sessions of counseling. A common shared decision is made with the family, the team, and the support. But it's not that once you tell, they will, okay, fine, we have understood and everything, and we won't question you again. We should not accept that, because at every point of time, they are seeing changes in the child, as Spandana said. So we need to be there to answer to them in case they want the explanation again, or if they want to change their decision, saying that now maybe we'll just stop and see if his symptoms are better off even without this. Yes, we should welcome that decision and do accordingly. So every point of time, even once you start the child, we need to have discussions to the family, in addition to artificial hydration and nutrition with the family, which has been covered very well by Spandana. I won't go into that detail. And at this time, there's a lot of time. Again, she has told about this, how well the parents can spend time with the child, because the child is just lying there and the parents are just seeing. So they should never ever feel that they're just waiting or hoping that the child might die. So we usually in hospice, it's easier to do this than in a hospital. We encourage on making memories and memory making for the family. Again, we don't tell them, do you want to do this or do you want to do that? We always say some families in this situation have preferred to do this or that. So would you like to do anything like that? So as already Spandana said, we usually ask them like that. So we should tell the family also that even the child, if is sedated, the child can always hear, and hence we need to encourage visitors to come and meet the child, talk to the child, play his or her favorite. Even in the hospice yesterday, it seems the child always liked Shah Rukh Khan songs. So we told them that you put the Shah Rukh Khan songs and put it on the bed next to the child's ear. So it depends again what the child liked and what the family wants to do. And again, holding, caressing, hugging, kissing, all that should be allowed. And because the child may not move much, we need to keep a close watch if there is any redness or in the bony areas or the pressure areas. And sometimes if the child is not able to blink, then we need to give her Moisol drops or cover the eye to prevent exposure keratitis. And again, when the family is just sitting there, we need to always empower them to take care of the child, so that they just don't sit and they're already distressed, they're sad. And instead of just sitting and then it's not that we can take out their distress, but if they're involved in something, that too, taking care of the child, maybe it will help them to feel better at that time or even later. So we tell them only to massage the skin, put oils, or do some aromatherapy or repositioning the patient, so that the caregivers themselves, the family, takes care of the child. So this is also a part of what we need to know, because once there is a palliative sedation which continues with different doses for an refractory symptom, the child is not conscious, the child doesn't eat anything simultaneously, the disease has progressed. So probably the child will die. It's not because of the palliative sedation, as already told. So we should also, of course, death is also planned as an advanced care plan before. We call it DCP, that is death care plan. So that is already planned with the family. So even after that, because we always say that if we don't plan it well at that point of time, it's not right for us to put them in that kind of stress when they are all in such grief and unimaginable sadness. So we need to help them with transport. And as you all know, you'll have this session next week. I think this is very unique to pediatric palliative care, bereavement support. Many a times, even all the health workers who take care of the child, many a times they are young and they might be even facing such a situation for the first time, and they get attached to the child because the child has been staying for so long either in the hospital or hospice. So a team debriefing, what we call, is very important after we lose the child. Only then the team again can take care well of the next child for who is sick. Otherwise it becomes very difficult when the team is not given a platform to vent out. It can be about talking good about the child, their memories with the child, their conversations with the child, what games they played, whatever it can be about the child. So it's just a team debriefing session. And now in the era of whatever legal and all these things, this is very important. Documentation of what all was planned, documentation of what all was spoken, and documentation of the care plan and what was done. So this general condition of the child should be written, the prognosis, the disease status, the anticipated survival, the refractory symptoms if not treated with palliative sedation, how much extent of the suffering the child will have. So by starting the sedation, what we are focusing, all this has to be documented. And even the method of sedation, of course, the place of sedation, either in the hospital or in the hospice. Sometimes if I think we had one child for whom we had to start this at home through a subacute port, but otherwise we have always given in the hospice and at in the hospital. Then the anticipated effects of sedation, the same thing, that the child might not eat on time, the child might not ask for water on time, or the child may not be immediately awake when you call. The child will sleep for longer and be awake for less number of hours. And then also the medical treatments and nursing care is to be maintained during the sedation to maximize the patient comfort. All these have, even the scales, the scores, everything has to be documented. So this is, I'm sorry, I could not get a better picture of this. So you can see this since the slides will be shared. I think I can't zoom. This is just a flow chart showing you when a child has a difficult symptoms, yes, then treat, then the difficult symptoms become refractory, and then you are in doubt whether it is refractory or still difficult, and then you can give medications, and when you see there is no much improvement, then all the family counseling, family communication, ethical part, all this comes about managing the refractory symptoms, and then you go to palliative sedation. Sometimes you're not very sure, and then you see that you think, okay, fine, I'll just give a trial of a little more aggressive short sedation, and then you see the outcome is better, and then you can stop. Initially only if you feel it's not a refractory symptom, then you need not plan with this at all. You don't need to go ahead with this plan. And when you give a trial, if you feel there is good, there is no still I mean there's no the symptoms are not treated, or there's no much of comfort, then you have to again go into family conference and go ahead with the palliative sedation. One important thing is that throughout this, I'm just zooming out, throughout this process following death, it is very important that our quality of the child should be the most important that we are focusing on. Family communication, again, multiple times I'm telling the same thing because it's very important, and the takeaway is interdisciplinary team communication and collaboration is important. The whole team should be in sync with what they are doing, and we should always give an opportunity for debriefing post death and engagement in bereavement support for families from the PPC team. Many a times, even when we have gone for bereavement support, there are mothers who say that the oncologist took such good care of us. won't he come or won't she come? So we felt very happy, and then if possible, we have requested even our oncologist to come with us, because the parents do remember, because all of you spend so much of time and in hoping for the cure of the child. So it's, we go for the bereavement support, but many a times the parents say that you have come, okay, we are very happy you care of all the symptoms, but we would like even to talk to the doctor, or the doctor who if he can come home, and we can have him home just like you. So it's very nice to hear when they say that. And this is just references, I think. Yeah, so thank you. This is about palliative sedation. Any questions and all that, we can take it on chat. I hope we have time. Yeah, 15 minutes we have. I'll just stop sharing.
I saw one question in the chat from, I think, Srishti, which says, Srishti, can you unmute yourself and ask the question? Because I did not understand the question. It says, how necessary is taking end-of-life care from parents in
No, I
stressful
think she
situations?
meant consent, EOL consent. I think C was consent. That's
Ah,
what I understood, not care, I think. Dr.
okay.
Srishti, please unmute in case it's not what we are thinking. So I thought she asked how necessary is it to take end of life consent from parents in a stressful situation. I think she should clarify that.
Yeah. But if it's consent, do you have an answer, Archana?
No, that's what I just typed. I told her, I mean, most of the times in EOLC, it doesn't happen in a minute or hours. Very rarely, yes, they can suddenly progress and go into end of life. But then still, we buy that time and we have multiple sessions of counseling. And then we make an advanced care plan in a structured way, which is a part of a communication. Again, I think you had it as serious illness conversation guide, where we talk about what if the child doesn't make it. So like Spandana has said, wish, worry, wonder, we use these terms, and then as a part of advanced care plan, we say if the child arrests, if the child stops breathing, then would you like us to keep the child comfortable? In that time, we take the signatures. It's not that in one point of time with one counseling, we tell them now you sign that you don't want this or that. So usually it happens in multiple sessions of counseling, because we need to give them time to think. Most of the times I give them the scenario. I tell them, I don't want a yes or no now. You go back, think over it, discuss with your family members, and then you can come back and let us know what you have thought about. Spandana, you want to add anything? Please go ahead.
No, I think that is right. Regarding documentation, parents signing it is not going to protect us legally. So if a parent says, yes, yes, I agree, and later they want to sue you, their signature is not the one that will protect you. They might just say, I was under a lot of pressure, and that is why I said what I said, right? So this is why what we say is our documentation, our observation, our communication documentation, these are the important things. Sunita, I saw your question. I'm sharing the link of
Yeah, I was
APPM
about to. Yeah,
formulary.
yeah. Okay.
So in that you can download a copy, and that is what we use. And I will also share our
But drug
handbook.
formulary, yeah, handbook. That I think.
Yeah, I'll just share that. Yeah. Any other questions, thoughts?
Yeah, there is one more question from Nikita, Dr. Nikita.
Sorry, is someone going to read or?
Yeah, so I'll just read the question. So it
Yeah.
says, ma'am, if the parents of the child want to still pursue some kind of treatment, in brackets chemo, and don't like palliation, even though they understand, sorry,
That the
even though they
disease,
understand
yes.
that the disease is restricted to all the modes of treatment given, how long should we be treating this child? Or can we deny treatment knowing that it's futile?
That's such a good question, Nikita. It's a tough one too. So one thing we did not discuss today is herbal treatments. Families use herbal treatments, and in the Middle East and even in India, they use cow urine and all these things, right? As medical professionals who went to a medical college, worked in medical hospitals, should we support it? Should we deny it? Is a question that comes up always. Same thing with chemotherapy. Again, from our point of view, if we deny them, if we take away their choice, do you think they will continue it under the table, or they will not seek other hospitals? Or do you think they will listen to you? I think that's the question. If you tell the family you're caring for, no, don't use Shimoga medicine, don't use some cow urine medicine. Do you think they will listen to us if we say don't use it, or do you think they will still use it without telling us? And if you say no, I will not give you chemotherapy, do you think they will go to a different hospital, or do you think they will listen to you? I think that this is very important. And in taking away the choice, sometimes these children who are dying are taken to a new team, and that is not helpful for the child. So again, and this is what Vinila does too in the hospice, right? Like we tell them, if you're taking something, just let us know. And be on the watch out for vomiting, diarrhea, and some other symptoms that will come through. And if any of these happen, let us know, stop the medicine. And there were many families that we have done home visits for. The child is having diarrhea for 20 days. What's happening? We are giving every medication possible. And then they bring out this bottle and say that we are giving this medicine. And then we say, do you think after starting this medicine, these diarrhea happened? If you fight with them, if you say you can't use, they're not going to listen to you. But if you make them see that this medicine is not helping them, that's when I think it happens. Again, the question is, Shruti, I totally agree. The decision to treat or not is their right, I think. But I think we also have to make sure that we are doing the best for the child. For example, there is neuroblastoma surrounding a huge vessel. And you know, if you operate, the child will die. And the family is telling you have to operate. Again, you might not be a surgical oncologist, but to remember, like, will we take this child onto the table and give treatment, knowing it's not in the best interest of the child? No, right? So again, the balance is how much we need to use and how much we need to stop is the balance. Vinila, do you want to answer what you have typed?
Thank you. So usually, like what we try to tell them is most of the time, like when, as Dr. Spandana mentioned, 99.9% of the families, the moment we ask that are they using or do they trust any of the alternate medicines, 99.9% always they say yes. But they still ask us, should we continue using that medicine or should we take that medicine? Is it, how effective is it? So we often tell them that one thing, like we are not experts in that medicine. Every medicine has its own uses and side effects and advantages and disadvantages. But we always give them the platform for them to take the decision. If you still want to use that medicine and if you want have the trust in that, you can always use it. But at the same time, should do not stop the medicine which we are using to make the child comfort. In case if we start this, the child may end up in suffering. This is what we often tell the other families. Yeah.
Thanks, Vinila. Any other questions, any other thoughts, any other experiences you want to share? I've shared two resources in the chat. The Two Worlds one is a global handbook that you can download. You can use it on your mobile phone. And APPM formulary is a PDF too, and you can refer to all the doses on it. Very quiet today. During communication, they were asking a lot more questions.
So, Vinila, do you want to
Yes.
make the announcement about
Yes.
the next class then?
Yeah. So
I think we have one more message. Yeah. Thank you, madam. Okay. So, Dr. Sunita.
Yeah, if there are no further questions, I would want to announce that in view of this Ramadan festival, which is going to happen on 20th, as per the calendar right now. So we will be postponing our last and final session of this series to 27th March, Friday, the grief and bereavement, which will happen on 27th March, Friday at 7 p.m. So that's the only announcement which I would like to make, ma'am. There is no session on next Friday, which is 20th March. The last and final session of this series will happen on 27th March. So I request Nandini to please post the post test and also feedback link in the group, and requesting all the participants to please kindly complete the post test and also feedback to improve our further sessions. Yeah,
There'll
ma'am, there
also
is
be
one
two
question.
more announcements in the next class so that we can, Dr. Gayatri Pallat will be joining in the next session and make the two announcements at the end of the next session.
So there is the one question saying that will there be any assessment at the end?
Usually we have an exam, no, Vinila?
Yeah, usually there will be an assessment, like a self-reflection kind of thing, which will be again on or online examination. Yes, ma'am, there will be an examination. Maybe I'll not call it an exam, but an assessment or self reflection or self-evaluation of whatever we have learned in the last 9 weeks.
Okay, ma'am. Thank you.
And I would like to thank both Dr. Archana and Dr. Spandana for giving their valuable experience and putting forward the entire group for discussion. I know it's too late. Thank you so much for being with us today, and looking forward for more sessions with you both. Thank you.
Thank you, Vinila. Thank you, Archana. Always a pleasure working with you both. Two of my favorite people from Hyderabad.
Same here. Thank you all, doctors,
Thank
also
you.
for joining us and sparing your time. Thanks again.
Thank you. Thank you, everyone.
Bye-bye. Good evening.
Bye. Good evening.